Hi, I'm Fred LeMaitre. I am the Physician-in-Chief for Blood Cancers and Bone Marrow Transplant for Sarah Cannon. I'd like to talk a little bit today about bone marrow, what it is, what bone marrow transplants are, and why we use them. We all have mother stem cells in our bone marrow that are capable of making blood in our immune system. And so when these things work properly, what happens is that these mother stem cells will receive signals when needed to tell our bone marrows to make more red blood cells to carry oxygen, platelets to keep us from bleeding, and we make a bunch of different types of white blood cells that are really important in fighting infection and in immunity. The reasons that we use bone marrow stem cells to do transplants are several. One reason is that sometimes we have cancers like Hodgkin's lymphoma, non-Hodgkin's lymphoma, or multiple myeloma that either are resistant to treatment or that we know are going to be very difficult to cure with the standard treatments that we have. In these instances, sometimes we can increase the dose of some types of chemotherapy drugs and overcome that resistance. The problem with doing that is that we will injure the bone marrow in trying to escalate the chemotherapy drug dose. So what we do is we take some of the patient's stem cells out ahead of time, freeze them away, and we can protect those cells from the potential damage that they might suffer from the chemotherapy. By giving the chemotherapy, we then can treat the cancer and we can reinfuse those cells so that we can rescue the patient from the side effects of the intensive chemotherapy. Now, there's other reasons we use stem cells too. Sometimes patients have problems with the bone marrow itself. Not always a cancer. Sometimes the bone marrow just fails to work. And obviously it's very difficult for patients who might have bone marrow failure, such as severe aplastic anemia, because they'll have low white blood counts and are subject to infection, or they may have low platelets and be at risk for bleeding. In these instances, we need to get a healthy bone marrow from somebody else and replace the patient's diseased bone marrow. There are other reasons that we use donor bone marrow as well. Sometimes we need to have, to be able to address a cancerous bone marrow, such as with acute leukemia, or in other instances, we have learned that donor bone marrow can actually help us cure certain types of cancers because the donor immune system may be more robust in terms of recognizing the patient's cancer, so that we get a double effect in terms of giving chemotherapy to prepare the patient and controlling their cancer, but we also are able to use the donor bone marrow and the immune system that comes with that bone marrow in such a way that the immune system from the donor attacks the cancer and helps us cure those patients. We're able to get bone marrow stem cells from a variety of sources now. I mentioned a minute ago that we were able to pull bone marrow actually directly from the bone marrow still in some cases. Most often now we collect bone marrow from the peripheral blood. By using certain medicines, we can mobilize stem cells into the blood so that we can collect the stem cells directly from the blood while the patient's comfortably resting in a chair, using a machine that filters these cells out and isolates them so that we can get collections of cells in very large numbers. Finally, we now have access to umbilical cord blood banks that have previously stored large numbers of cord blood units. These umbilical cord bloods are rich sources of stem cells, and they're capable of repopulating the bone marrow. So now it's possible to find a donor for most patients in the settings where we need to do donor transplants. There have been some tremendous improvements in the way that we do transplant and in outcomes. The advances have occurred in access to treatment, in terms of how we prepare and care for patients before the transplant as well as after the transplant. The preparative regimens we now use are much more tolerable than they used to be. We've learned that we can adjust the doses of chemotherapy medicines to the patient's needs, and this allows us to be able to address the problems of many more patients than we could formerly. By being able to do these adjustments, we now can treat many patients who are older and who have other medical problems that we previously could not. So for many centers now, it's not uncommon for us to be able to treat patients who are in their 70s and sometimes beyond with these treatments. In addition, we previously were limited in our ability to treat certain patients who had problems with their kidneys or their heart or lungs. And because we're able now to use these medicines more safely, we can offer this potentially curative treatment to patients where previously we could not. This has greatly expanded our ability to allow access to patients for transplantation therapy. And patients who have particularly blood cancers or bone marrow failure problems should actively engage their physician to ask about transplant, not only as a resort for cure after their cancer has come back, but in many instances now we're able to identify the cancers that are so high risk that we really should be considering doing transplant in earlier remission states. So sometimes acute leukemias, which have bad prognostic markers, either in cytogenetics or in some of the newer molecular markers that we now measure. We know these patients don't do very well with standard treatments, so once they're in remission, it's often helpful for them to be referred for evaluation early on. The same is true for many of the lymphomas. Additional advances that have occurred in terms of transplantation therapies have been in our understanding about how to prevent recurrence of cancer after the transplant has been done. These efforts have mainly been focused in manipulating the donor immune system in the setting of donor transplant, where we now know that the immune system is very powerful in terms of helping to control the patient's cancer. And by manipulating the donor immune system, we can reduce the incidence of relapse. Sometimes it's as simple as being able to collect more immune cells from the donor after the transplant has occurred if we think that there is an ongoing risk of relapse or if the cancer has indeed come back. Increasingly, though, we're learning that in the setting of both the donor transplants and in the setting where we use patients' own bone marrow, that we sometimes can use medicines to help prevent the cancer from coming back. This is now standard of care for the autologous transplantation of multiple myeloma. And let me define autologous for you. That means we're using the patient's own bone marrow stem cells. In autologous transplantation in myeloma, it is now standard of care to use maintenance treatments after the transplant, and this has been shown to greatly prolong the remission intervals after transplantation. The final thing that I would say is that we also know that there is a tremendous unmet need for being able to deliver transplantation therapies for patients. We're still trying to understand all the barriers that patients face in getting to transplant centers. Sometimes it's logistical, many times there may be insurance or other kinds of problems, but we also think that there may be an underappreciation of the role of transplantation therapies in many different types of cancers. The National Marrow Donor Program has conducted some surveys, and by some estimates, there may be as many as 5,000 patients a year in the United States who could be transplanted or who need to be transplanted who just are not being referred in for transplantation therapies. So I think it's really important for patients to question, to be interactive with their physicians, and in situations where they have cancers that may be addressed with transplant, to ask for some advice about referral.